Welcome to this guide on one of the most critical and frequently misunderstood documentation topics, the distinction between Type 1 myocardial infarction, Type 2 myocardial infarction, and non-coronary causes of elevated troponin. Think of an elevated troponin as the start of a question, not the answer. Let's explore how to assess and document these cases. First, let's clarify our vocabulary, as these terms are not interchangeable. Myocardial ischemia is a clinical and ECG finding. Myocardial injury refers to an elevated, clinically significant troponin. Myocardial infarction is the combination of both, acute injury plus evidence of ischemia. Remember this equation as we proceed. Focusing on the lab aspect, myocardial injury is defined by a troponin level above the 99th percentile of the upper reference limit. These limits are sex-specific, below 20 picograms per milliliter for men and below 14 for women. A high troponin confirms injury, but it does not tell you why. Clinically, we must broaden our understanding of chest pain. Symptoms of acute myocardial ischemia go beyond simple chest discomfort and include pain in the upper extremities, jaw, or epigastric region. Always consider dyspnea and fatigue as potential anginal equivalents, even if the discomfort is diffuse or atypical. The second part of diagnosing ischemia involves the ECG. Look for 4 key changes: street segment elevation, which indicates a potential STEMI, Saint segment depression, T-wave inversion, or the development of pathological Q waves. Any of these new findings alongside clinical symptoms provides the evidence of ischemia required for a diagnosis of infarction. The definition of infarction is clear: acute injury plus evidence of acute ischemia. Per the universal definition, evidence of ischemia can be demonstrated by symptoms, new ECG changes, specific new wall motion abnormalities on imaging, new Q waves, or the identification of a coronary thrombus on angiography, the latter specifically indicating a Type 1 myocardial infarction. When assessing troponin, always read the trend. An abrupt spike followed by a slow, gradual recovery suggests a myocardial infarction. In contrast, a flat, steady elevation typically indicates injury only, often stemming from a non-coronary cause. Reading the trend is a crucial first step before assigning a diagnostic type. There are 4 primary pathways for an elevated troponin. These range from Type 1 MI variants, such as STEMI or NSTEMI, to Type 2 MI caused by supply-demand mismatch or non-coronary myocardial injury. Understanding these pathways helps determine the correct clinical management and accurate documentation for each patient. Type 1 MI is a primary coronary problem. A STEMI involves an acute coronary thrombus requiring immediate reperfusion, documented by vessel or segment. An NSTEMI is caused by plaque rupture or erosion and is managed with heparin and early intervention. Both require injury and evidence of ischemia. Type 2 MI results from a supply-demand mismatch rather than a primary plaque event. Management focuses on treating the underlying cause, and invasive procedures are generally not indicated. Whether the cause is cardiac, such as a tachyarrhythmia, or systemic, such as hypoxia or severe anemia, it is vital to document the specific cause. Non-coronary injury is not an infarction at all. This occurs through non-ischemic mechanisms, like direct cardiac injury, stretch, or other systemic issues. Conditions like heart failure, myocarditis, or renal failure can cause this. Here, you should document the findings as myocardial injury due to the identified underlying condition. Avoid common documentation misses. Never write vague terms like MI or AMI without clarification. Avoid listing just Type 1 or Type 2 alone, as these are not specific enough for coding. Similarly, replace vague phrases like new onset with specific diagnostic descriptions to ensure clear, codable documentation. To summarize, remember these 5 habits. Injury is not infarction. Always read the trend. Type 1 relates to coronary events. Type 2 is a supply-demand mismatch. And finally, document with precision. Applying these habits will ensure your records are accurate, specific, and clinically sound. Thank you for viewing this video.